Uh, I'm going to start with complex regional pain syndrome, also known as CRPS. It used to be formerly known as RSD. I know this is a kind of a busy slide, but I just want to sort of look at the highlighted sections. It's number one, it's a continuing pain. It's not, it doesn't, this pain never goes down to 0 or 10. So one of the key questions we always ask these patients, does your pain ever go down to 0? And if it does, then it's most likely not CRPS, it's something else. They do have spontaneous flare-ups. It's obviously the predominant symptom in these patients is pain, and it's disproportionate to the time or degree of the course. So if somebody had a fracture of their arm and it's been a year, 2 years, 3 years, and they still continue to have severe and excruciating pain, that should trigger thoughts of CRPS. They also have other abnormalities, like which are related to their sensory and motor functioning, which we'll get into that a little later. And then the condition can actually have a variable progression over time. In some cases, it gets to be worse and worse, and in some cases, it just plateaus out. And there have been also cases where it has gone into remission. Officially, there are 3 types of CRPS. There's CRPS1, formerly known as reflex sympathetic dystrophy, or RSD. And then there's CRPS type 2, formerly known as causalgia. And then there's something called CRPS NOS, not otherwise specified, which means that the patient kind of meets the criteria of CRPS, but not quite. It might be somebody who's in the healing stages or has become so chronic that it's not meeting the criteria, but we don't, in practice, we just use, in reality, in practice, we just use the 2 types, CRPS1 and 2. The difference between CRPS1 is that in CRPS1, it's a non-specific nerve damage. So the entire limb is affected. There's no specific nerve that's been affected. They have general diffuse pain to that limb or limbs. In CRPS type 2, there is a very specific nerve damage. And oftentimes you'll see that they had some sort of a trauma or a wound injury that's damaged their nerve, and they ended up having CRPS type 2. And this was actually how it was first initially diagnosed in World War I, when there were soldiers coming in with bullet injuries to their arm, and they had pain shooting down their arm, and that was initially recognized to be CRPS. And it was actually CRPS type 2. The symptoms and signs are almost the same. The difference lies in some of the treatments. The common causes of CRPS is usually after a trauma, it's usually after a fracture and immobilization. One of the things that I just want to remind you is that if a patient has a history of, or comes in and says that, they have their limb is in a cast and they're still having severe pain, it should trigger thoughts of CRPS. It can happen after a simple sprain. Needle stick injuries are very common. They can have that. In some cases, it can be from prolonged immobilization or brain injury. CRPS from brain injury is a whole different condition called central pain syndrome. Some of the terminology that's used in describing CRPS is hyperesthesia, which is really just a weird sensation to touch. Oftentimes it's creepy crawly sensation, not really pain, but just a bad, yucky sensation. Allodynia is pain to soft touch. They will not let you touch. They will not let you even come near that limb. Dystonia is a movement disorder in which these muscles contract and they sort of just tighten up. What it is not, it is an amplified pain syndrome. It's often referred to as amplified pains. Sometimes some practitioners call it amplified pain syndrome. The reason I brought this up is because if a patient comes into you and a client comes and says, hey, I have been diagnosed with amplified pain syndrome, think of CRPS. It's really just another name for CRPS. The diagnosis of CRPS is based on a very definitive criteria, and the criteria, one of them is a temperature difference officially, they say a temperature difference of 1 degree is enough between the affected and the unaffected side. In reality, we see a much higher difference. And it's both subjective and objective. So patients might tell you, hey, my affected side is really warmer or it's really colder than the normal side. Even if they have CRPS on both sides, you can oftentimes see a temperature difference. See, the problem lies in when you have it in the axial skeleton, if it's in the torso, abdomen, or chest wall, then it's hard to get a temperature difference. But you can also see that maybe the upper abdomen to the lower abdomen, there's a temperature difference. Color difference is very obvious. You can see the limb looks different. And again, later on, you'll see some pictures. That limb might look red, blue, green, gray, sorry, not green. And the temperature, the color difference comes and goes. We tell our patients to take pictures of both limbs when they see a color difference, so that, and you can look at them in the office and see if there are the color difference. Signs and symptoms, the pain usually starts in a limb, but it can start in any part of the body. It is a constant pain, which with spontaneous exacerbations, temperature difference, color difference. They have swelling. Swelling is more common in the acute stages. Often in the chronic stages, you may not see swelling. Again, I'll show you some pictures later on. What's important is that the pain is usually in a larger area than the primary injury. So if somebody sustained a foot injury, right foot injury, the pain is maybe in the entire leg, or even on the other opposite leg also. They may have increased sweating. It's not common, but they do have increased sweating. It is actually in the diagnostic criteria. They can have a very, very uncomfortable to touch. It's pain or very uncomfortable to touch. They may have nail growth changes, and I'll show you some pictures. The nails are they're brittle, they grow faster, they're distorted, ridged. Hair growth changes, you'll see some hair growth. It may be darker, or it may say less hair also. In the acute phase, in the initial stages, the skin might be shiny and thin. They can have blisters, and they can vary anywhere from pinpoint blisters, lesions to blisters, and again, increased sweating.
Let's move a little bit into chronic regional pain syndrome, and talking about sort of like some of the beginning things. He talked about this whole idea of
kinesiophobia.
Thank you. Kinesio. I cannot say it.
Kinesio. It's like kinesio.
Kinesiophobia. There we go.
Right.
Thank you.
Yeah. Fear of movement is a big predictor for disability. There's actual, assessment tools to measure how fearful someone is of movement. And what I think Feldenkrais offers is this ability to discover that you actually have some ability to move without injuring yourself in all the ways that we do this, right? In the moderating or modulating how far you go, how fast you go, how many times you go, and really developing that sense of doing this for yourself, that I can versus I can't, which is right, the phenomenologist's way of describing the sense of agency, being able to move forward. Everyone I've worked with pain is afraid. They're afraid to come to see you. They're afraid what you're going to ask them to do. They're afraid to be touched. And in chronic regional pain syndrome, that is really prevalent because it's like their body has betrayed them. Like, what the heck is going on here? And how do I begin to use this nervous system that I have? And people like, I love that Dr. Chopra said boot camps are no good for this kind of person. Like that, there's a big thing in the NPR recently about children with CRPS being put in these boot camps and made to do these things. And then you look at the results, it was like the results weren't even supporting the benefit of doing this, that 3 years later, they still had pain. It's like what you're saying about the culture of flexibility. In our culture, it's the culture of strength. Whatever is the problem, getting stronger is going to fix it. And certainly that is one component of fixing it or dealing with it.
Or blaming the patient.
Blaming is really that's a
Blaming the
good
client.
strategy.
That's right. That's right. They really, you're feigning this because RSD is, it is a very profound problem. I mean, I understand now the word is supposed to be CRPS. I understand that. But I think so often I find that the patient is getting blamed for the problem, that they're inventing it. They're being hypochondriacal. They're imagining.
One thing that. Go ahead.
But I'll just finish. I had told Deborah that I have 3 clients who actually are patients, have been patients of Dr. Chopra's, and they all felt that seeing him, and we saw what a beautiful person he is, that seeing him, they felt like finally it was the first time they'd met a medical professional who understood them and validated their experience.
Yeah. I mean, actually, all of us here in this conversation have had a lot of connection to the medical world in one way or another. And I worked with hundreds of physicians, and I think one of the problems, and even Feldenkrais practitioners have to watch this in themselves. One of the problems is that we want to be able to help people, and then when we can't help people, unless you have a high level of maturity, it appears to be human nature to blame the person that can't be helped, that's somehow their fault that you can't help them. And that's what I see as often as has been the go-to stance. And I don't know that it has anything to do with the medical field per se. I think it has to do with our maturity and our ability to accept that sometimes we may not have the resources to bear for that person, and that doesn't mean that they're to blame, that they didn't try, or they're making it up or whatever. I love that he just came right out and said, this is not a psychological issue.
Yeah.
Right. This is what so many people think. And I've had referrals from pain management doctors, which I think, no wonder you're not getting better, because the doctors already preclude me into thinking, hey, this person's got a psychological issue here.
That's right.
Well, that's how you start your referrals. I mean, I would never say that to anybody, but I'm thinking, gosh, you need a different doctor. I mean, if I knew someone else to refer them to, that would be another thing. I don't really have a good option right now in Cincinnati, the one I had moved away. But I did have one, and he was like a night and day. This guy never referred anybody with any kind of hint of blaming the patient or the client in any way.
Yeah.
So,
if we think about like that just to say someone has a psychological problem already is separating the mind and the body.
It is.
And of course you have a psychological problem. You're scared, you're depressed, you're angry, you're worried, you don't have any hope. I mean, of course, like that's a natural problem.
Right. That doesn't make it the etiology of the problem, however.
Exactly.
That's right. It's not the etiology. So yeah, that's such a shame when someone is treated that way, because again, I go back to we listen to the whole story. We listen to the whole person of what they're saying. For chronic regional pain syndrome, I've only had a few people with that, but I remember where they couldn't be touched on that side. So I started to think of some of the things I remember from Feldenkrais talking about judo, that you look in a different place when you're going to grab somebody, right? So you kind of telegraph your movements to confuse the person. They think, oh, I'm going to grab your right arm because I'm looking at your right arm, but actually I'm going to grab your left arm. So with CRPS, that's some of the stuff that I did. I would stand, say their right arm was the problem. I would never stand on the right side. I would stand on the left side and reach across to touch the right, which was a novel thing for them. And I could actually touch someone, because if I was on the right, just that sense of my hand going to the right arm brought up the expectation of pain. Like I didn't have to touch them other than just for them to have that expectation. So I think that there's a lot of ways of using tricks of attention, tricks of how the nervous system deals with expectation, with that. And for one woman, it completely changed her. She no longer had the problem, and she had all the symptoms of the hair growth on one arm and sweating, but she also had a huge trauma in that her child died while she was present at a church function, cooking dinner, and the kid ran out and got hit by a car in the parking lot. So often there was this psychological trauma that, working closely with the psychologist in me, she was able to do quite well. She still had pain and, a lot to process, but that whole focus of the one arm being the, I guess, the kind of how it showed itself, this whole problem, how it showed itself as that kind of opened up, especially with being on the opposite side of her, was a very simple thing that worked.
And a good number of these people start with a fracture to a limb, and they actually go to be casted. And when they are casted, when the cast is put on, instead of getting comfort from the cast, they immediately start having increased significant pain. And Dr. Chopra, we had to redo a little bit of his, but he talked about, and when he talked about this in the first interview that we had to tape over, he said, when you have someone like that, that cast needs to come off. You have to come up with a different solution, or you'll solidify the chronic regional pain syndrome. It was very interesting.
That's good to know. Yeah.
And I was fascinated by the obviously the connection with dystonia, with focal dystonia. I mean, all these things where the nervous system, and I think there's a special place where the nervous system is generating the signals spontaneously, even in the absence of the necessity for the thing, right? I think it just I find, and anyway, he mentioned it was just for a microsecond, but he said, and dystonia disorders.
He did. Yeah. He did. So I think what we wanted to, and I hope we did, is give people a clear sense that no matter what the diagnosis, there's some level, and sometimes a huge level of improvement that can be made in the quality of how you are living your life. And what I think maybe one of the things that Feldenkrais practitioners have the most to offer, hopefully, is an ending curiosity. So we have learned to be curious and to wonder about the possibilities. And hopefully we can instill that in our clients and awaken that curiosity and to wonder about the possibilities. And I'll tell you, life changes a lot when you're no longer only consumed by everything that's wrong. I mean, just a single glimmer of something that goes well. I think, Deborah, it might have been you in the other talk talking about success. I mean, a small piece of success can change your whole day, maybe a week and a month.
That's right.
And the brain begins to look for it again the next day.
It's hungry for it. Yeah.
That's right.
That kind of privation that Dennis Leary liked to talk about. So beautiful.